Namaste. I am Dr. Shaima Kadri from Faculty of Physiotherapy and Diagnostics, and today in this video we are going to discuss about olecranon fracture. So let's begin. Olecranon fracture frequently occurs with elbow disorder. These fractures are regarded as one of the simplest articular lesions and its operative and physiotherapeutic treatment are straightforward. These fractures are mostly intra-articular and are generally associated with joint effusion and hemosis. Extra-articular features include avulsion fracture and are most commonly seen in the elderly. The elbow joints are made up of the following joints: ulnar humeral joint, functional stability, elbow flexion extension, radiohumeral joint, functional lateral stability, forearm pronation supination, proximal radioulnar joint function, forearm pronation supination. Olecranon function. Insertion point of triceps turn plays important role of extensor mechanism of the elbow. Major articulation of elbow joint. Epidemiology or etiology. Mechanism of injury. Direct fall on forearm. The olecranon is focused into the distal humeral by hyperextending the elbow on the outstretched hand, penetrating injuries affecting the articular surfaces, indirect through triceps contractions. The contraction of the triceps avulse the olecranon and tear the distal triceps expansions. Postman, example wrestlers and gymnasts, that generates a lot of isometric arm power. Example wrestlers and gymnasts at our risk. The clinical features are patients with a broken olecranon are unable to extend their arm. Classification. The classification system of olecranon features are based on the displacement of the olecranon, communication and elbow stability. There are three types of fracture, each with two subtypes. Type 1, non-comminuted and minimal comminuted fracture. Type 2, displayed fracture with intact ulnar collateral ligament, displayed versus non-displayed, stable fracture. Type 3, fracture with disruption between the forearm and humerus, displayed versus non-displayed, unstable and a result of disruption of medial collateral ligament. Diagnosis. First, we are going with assessment as physical examination, subjective interview, mechanism of injury, direct blow to the blow, complaints, pain over elbow, inability to extend elbow, observation, deformity, obvious around elbow, forearm appear shorter, distortion of the bony landmark of elbow, swelling, bruising, palpation, tender overtip of olecranon and proximal ulna, palpable gap at fracture site, range of motion limited elbow extension, neuromuscular examination of the hand to rule out. So, uh, observation, deformity, obvious around elbow, forearm appears shorter, distortion of the bony landmark of both elbow, swelling, bruising, palpation, tender overtip of the olecranon and proximal ulna, palpable gap at fracture site, range of motion limited elbow extension, Neuromuscular examination of the head to rule out confounding intent. Investigation as investigation is done, there is actually is done in the AP and the lateral view. The medical management of olecranon fractures depends on displacement, comminution and elbow stability. Primary elbow instability and fracture morphology are orthognostic fractures for elbow function and overdevelopment of arthrosis and operative treatment. The aim of this management is to restore the extension mechanism of elbow and reconstruct the articular surface. Type 1, 2 week immobilization and symptomatic treatment. Risk of displacement as a result of tricycle. Type 2 and 3 require surgical fixation. Surgical intervention. Tension band wire fixation indication non-communicated process fracture involve less than half an articular olecranon surface. Complication loss of fixation, non-union, skin breakdown, infection, olecranon bursitis, radial and subluxation, radial head subluxation, prominent hardware, plate fixation, indication comminuted fracture, good outcome with regard of union and prevalence of hardware complication, intramedullary screw fixation, olecranon excision and crisis adjustment technique. The complications are permanent extension loss, hypertrophic ossification, non-union, malunion. Physiotherapy management is post-operative care is very important for maximum healing. The function goal of the physiotherapist is to restore the normalized activity of daily living. Rehabilitation and done bone healing will take approximately 12 weeks. Week 1, inflammatory phase. A splint or cast is applied for fixation in 60-degree elbow section to minimize tension on the skin. Assess capillary refill sensation, active and passive range of motion of the disease, excessive swelling, commence activity range of motion of the shoulder, hand and wrist. Edema assessment after 3 to 4 days, isometric exercise of the wrist, gentle active elbow fixation, active range of motion of the wrist, each patient functional adaptation example, use the uninvolved extremity for the self-care activities. Week 2, repetitive phase, reparative phase, none is minimal stability in the elbow, extension of the elbow is 90 degrees, is not permanent. In cast or splint or cast remove in most cases, gentle isometric exercise of the biceps, isotonic exercise of biceps. Week 4 to 6 for fracture are permanently stable. Active and active assisted range of motion of the shoulder, elbow, and wrist. Avoid passive range of motion at the elbow. Isometric exercises to the elbow and wrist is inflection and extension activity of daily living. Uses for the affected extremity for stability and light self-care. Week 8 to 12, if fracture is clinically and radiographically healed, prog- progressively weight bearing to affected limb, resistive exercise to elbow, flexors and extensor, active assistive range of motion to the elbow and wrist in all planes until satisfactory range is achieved. There may be some limitation of elbow extension, gentle passive stretching may be necessary. Dynamic sprint may be used for the passive elbow stretch. So this is all about the fracture of olecranon process. Hope you understand it well. If you have any queries related to this video, ask me in comment section. This video is powered by Digital Version of 2.0 JOT Vidyapeeth University. Namaste. Khush rahiye.